Hey, hello everyone. All right, so let me know if there's any problems hearing me, and I'll check the questions at the end. I'm gonna leave, like we've been doing, kind of leave a half hour for questions, but type them in the comments. I will try to get to as many as I can before it gets too late. All right. I'm going to get started with the talk now. So I have some slides. It'll be half an hour. We'll go through the slides, and then the second half hour will be for Q&A, answering all the questions that have been asked, or dealing with all the questions. Okay. Let me see. If you have any problems hearing, let me know. Just trying to view all these. Okay, I'm going to put the slides up again. All right, here we are. So I'm Dr. Deva Boone from the Southwest Parathyroid Center. Tonight, we're going to talk about secondary hyperparathyroidism. This is super important, one, because it is very often misdiagnosed, and a lot of doctors aren't very good at treating it. So I deal with it a lot, actually, even though I'm a parathyroid surgeon and most cases don't need surgery, I deal with this quite a bit. Okay, so secondary hyperparathyroidism. What is it? Now, I contribute to the confusion sometimes because when I talk about parathyroid disease, I just say parathyroid disease, right? And what exactly am I talking about? Most of the time, I am talking about primary. Primary hyperparathyroidism is what most people are thinking of when they think about parathyroid disease. Primary hyperparathyroidism is the one where you have the high calcium, you have a parathyroid tumor, you need surgery, the only treatment is surgery. Secondary hyperparathyroidism is a little different because it is treated very differently. The causes are very different. But just looking at it from a symptoms point of view, it's actually pretty similar. So people can have the same symptoms, the same problems related to secondary that they have with primary. So you can still feel tired, you can get bone pain, you can get kidney stones, you can get osteoporosis, gastrointestinal issues. These are all really common in patients with secondary hyperparathyroidism as they are in patients with primary hyperparathyroidism. So we can't really distinguish these two based on symptoms. Okay, so secondary hyperparathyroidism, just like I said, fatigue, brain fog, increased urination and thirst, bone pain, kidney stones, osteoporosis. You'll recognize all of these things as primary hyperparathyroidism manifestations, but they're not in this case. So, broad overview here. Primary hyperparathyroidism is when the parathyroid is the problem. So, you've got a problem and it starts with the parathyroid. With secondary hyperparathyroidism, there's a problem, but it did not start with the parathyroid. The underlying issue started with calcium. Either your blood calcium's too low or you have a problem with calcium absorption, something to do with calcium. That is what caused the issue. Okay, so if the parathyroids are the underlying issue, meaning you have a parathyroid tumor that grows, that's primary. If there's some other issue that causes the parathyroid glands to make too much hormone, that's secondary. So hyperparathyroidism means overactive parathyroids. Primary means they're overactive and it's their fault. It's the problem with the parathyroid. Secondary means they're overactive, but it's not their fault. They are trying to do the right thing. Now, I'll explain more of that in a minute, but basically, secondary hyperparathyroidism, remember, the problem is not starting with the parathyroids. The parathyroids are actually doing their job. They're just having to work a little too hard. Now, you'll notice there is tertiary hyperparathyroidism, which a lot of people may not know about. I don't talk about it that much because it is pretty rare, but it is essentially when you have long-standing secondary hyperparathyroidism, it can occur. For most patients, it will not. If you have long-standing secondary, you will just continue to have long-standing secondary. But tertiary is a weird one because it can kind of look like primary hyperparathyroidism. You can't have all of these at the same time. You can't have primary and secondary at the same time. You either have one or the other. There was somebody who commented initially about having both. It's not really possible given just the definitions of what they are. It's not really possible to have both. But what you can have is tertiary, which looks a lot like primary, but actually is long-standing secondary. And tertiary, it sounds like tertiary hyperparathyroidism is actually what's going on here. So let's go forward. So primary, parathyroid's the issue. Secondary, calcium's the issue. All right. So parathyroids, we went over this before. The parathyroid glands are the thermostats for calcium. So when the normal parathyroid glands, when your calcium level's too low, they make more PTH. They want to bring up your calcium, right? That's what normal parathyroid glands do. If they have to make a lot of PTH to keep that temperature in normal range, keep the calcium in normal range, that is called secondary hyperparathyroidism. Okay. So again, secondary hyperparathyroidism is the hyperactivity of the parathyroid glands in response to low calcium levels or some problem with calcium metabolism or calcium absorption. Okay. It seems like I'm repeating myself, but I kind of have to say it in different ways to make sure that everybody's getting the basic concept of secondary hyperparathyroidism being the parathyroid glands trying to do their job. Okay, so to compare, and this goes over kind of the basic ones and how we can distinguish them. So again, the underlying problem is different. The symptoms, they both have many symptoms. You really can't tell the difference there. The big way to tell the difference between primary and secondary is to look at your blood calcium level. So blood calcium level, if it is high, that cannot be secondary hyperparathyroidism. Just full stop. It cannot be. With secondary, the blood calcium level is low or low normal. Especially with the ranges that some labs give, they're giving a range that is way too broad. And so it may look low normal on the labs, but actually be low for a human. So something like 8.8, it's possible that your lab will show that as normal, but that's not normal, 8.8 milligrams per deciliter. Most adults want to be in the mid to high 9s in milligrams per deciliter, and you'll remember that from the primary hyperparathyroidism talk. But if you're continually below that, if you're in the high 8s or low 9s, that is low, and that can lead to secondary hyperparathyroidism. Okay? If your blood calcium level is high, it's not secondary. High normal is kind of a gray area, but mostly if you have a high normal calcium and a high PTH, you're going to have primary. PTH levels, both high. With primary, it doesn't have to be high. It can be normal. With secondary, it has to be high. That's part of the definition. So you're not going to tell the difference based on PTH level. This is why when patients email me or message me and they ask, do I have parathyroid disease? And they just give me a PTH level, I tell them I don't know what the issue is, right? Yes, I can tell you that your PTH is high, but I have no idea what you actually have. I can't tell you that you have primary hyperparathyroidism or secondary. I can't tell you anything unless you tell me your calcium level. And if your calcium level is low and your PTH is high, then I know it's not primary, it's secondary hyperparathyroidism. Okay, And then the treatment is different. With primary, there's only one cure. There's only one way to cure this condition, which is surgery. With secondary, surgery is usually not the answer. There are a couple of exceptions, but in most cases, what we want to do with secondary is treat the underlying issue, the issue that caused the problem in the first place. And remember, the underlying problem is not the parathyroids. Okay, so again, to reiterate, the labs. Secondary hyperparathyroidism, low or low normal calcium levels, and a high PTH. This is pretty straightforward. This is secondary hyperparathyroidism. Okay, now let's get to the causes, because for most people, there is a cause. You can figure out the cause just by talking to somebody, getting a history. Okay, number one is renal failure. This tends to be the one that doctors know the best, and sometimes the only one they know. It's not the only cause though. And when I say renal failure, I'm not talking about a mild decrease in your GFR or a mild kidney disease. I am talking about close to dialysis or on dialysis. That's where you have to be to get renal failure causing secondary hyperparathyroidism. And when that happens, so for pretty much everybody who's on dialysis, you're going to have some element of secondary hyperparathyroidism. That's just what happens. What happens over time is that you have a chronically low calcium level and high phosphorus level, and you get very high PTH levels with renal failure, very, very high. But this is not what I most commonly see. Most patients who come to me with secondary hyperparathyroidism do not have renal failure. They may have a mild chronic kidney disease, but that's not what's causing the PTH to rise. That doesn't do it. You've got to be pretty close to dialysis for it to start doing that. So more commonly, this is the more common cause, is malabsorption of calcium, meaning your intestines, for whatever reason, are not absorbing calcium as well as they could. And there are various causes of this, and I will get to this on another slide, kind of going over more details. But basically, there are a lot of things that can cause you to not absorb calcium and other nutrients. Things like chronic diarrhea. If you've had a gastric bypass, this is not uncommon. A lot of people with gastric bypasses will develop secondary hyperparathyroidism because they are bypassing the area of active calcium absorption, which is the duodenum. Any operation where your duodenum is removed, like a Whipple operation, or part of the intestines are bypassing the duodenum, like a gastrectomy, that can do it. A severe vitamin D deficiency. We're not talking about a mild vitamin D deficiency. A lot of people have mild vitamin D deficiencies. You've got to have a pretty low vitamin D for it to really spike the PTH, but it can happen. Remember, vitamin D, one of the main roles for activated vitamin D is to help the intestines absorb calcium. So if you have inadequate vitamin D, then your body's going to have trouble absorbing calcium, and that is going to be a chronic issue. Okay, next one is, an impaired absorption from any cause. I'll get to that more in a minute. Renal calcium leak. This is one of my favorite ones to talk about because it is often missed. So it's very common for doctors to not remember this or not think of it as a cause of secondary hyperparathyroidism, and as a result, it's often missed. The treatment for it is a little bit different than all of the others, and so you have to be able to diagnose it and figure out that it's going on. And if you're not aware of what it is, then there's a good chance you're not going to be able to do that. So renal calcium leak is when the kidneys just release too much calcium into the urine. Full stop, that's it. They're releasing an inappropriate amount of calcium. So we all have calcium going through our kidneys, right? It's in the blood, it's going through the kidneys. The kidneys are filtering out lots of things and electrolytes, and some of them they're putting into the urine, others they're kind of pulling back. When you have renal calcium leak, the kidney is otherwise working okay. It's working normally. The only thing it's doing wrong is that it is putting too much calcium into the urine. That's renal calcium leak. And because of that, because you're losing calcium into the urine, your blood calcium level can drop. And when your blood calcium level drops, then you end up getting secondary hyperparathyroidism because your parathyroid glands have to work harder to get that calcium level back up or keep it in normal range. And finally, inadequate calcium intake. So, most people are getting enough calcium in their diet. A lot of people are getting enough calcium in their diet, but there are people who don't get enough either because they have dietary restrictions or because their body needs more calcium at that time. This is the one I see in patients I see fairly common in patients who are post-op from parathyroid surgery for primary hyperparathyroidism. So they've had surgery, they had primary hyperparathyroidism, classic disease, they had high calcium, high PTH, they have surgery now. Now you check their labs a month after surgery and the calcium level is on the low end and the PTH is on the high end. Patients will often freak out thinking they're not cured, but actually you are. It's just that your body still needs more calcium. And that's why the calcium's a little on the low side. That's why the PTH is a little bit elevated because it's still trying to get more calcium. If you've had significant bone loss from parathyroid disease, then you have a higher calcium need. I do recommend everybody take calcium and vitamin D after surgery, and sometimes you need higher doses, and I recommend staying on it for at least 6 months to kind of replace that calcium. But I do see this, and I also see this in patients who have a lot of dietary restrictions around foods that contain calcium. Okay. All right, just to reiterate the causes of malabsorption, because this is the most common thing I see causing secondary hyperparathyroidism. So it's worth repeating all of this. So chronic diarrhea of any cause. It could be Crohn's disease, it could be celiac disease, it could be IBS. A lot of people have IBS and they are dealing with multiple loose stools throughout the day. That's going to make it hard for your intestines to absorb the calcium. And so that can lead to secondary hyperparathyroidism. The surgery on the stomach or intestines, I mentioned the gastric bypass, but again, anything where you're removing part of the intestine or the duodenum. So a Whipple procedure for pancreatic cancer, for pancreatic disease, any extensive bowel resection. So if you've had a lot of your small intestine removed, or if you've had your entire colon removed and you've got an endoleostomy and you've got chronic diarrhea from that or lots of watery stool, all of those things are going to lead you to have malabsorption, and calcium is one that is more easily affected. So a lot of different operations on the intestines can do it. The big things are the stomach and the duodenum, but anything extensive further down the tract can do it as well, especially if it causes chronic diarrhea. Severe vitamin D deficiency, we mentioned that you have to be pretty severe, but it does it. Okay, medications. So this would be under the other category. Certain medications can affect calcium absorption. Proton pump inhibitors are one of the big ones. These are medications used to treat GERD or heartburn. They are things like omeprazole or Nexium or pantoprazole. They tend to end in azole. They affect the absorption of calcium carbonate. They don't really affect the absorption of calcium citrate. So if you're taking calcium citrate, you're okay. But a lot of the calcium added to our food is calcium carbonate. And so you can have some issues absorbing the calcium because of the PPIs. And finally, dietary factors. So when I talk to somebody with secondary, I always ask about their diet, and I ask about oxalates. Oxalates are present in high amount in things like spinach. Spinach is actually the highest, it's the worst. And it binds to calcium. So even though spinach actually has calcium in it, you don't really absorb it because the oxalates in it bind to the calcium and prevent you from absorbing it. So if your diet is high in oxalates, this can be an issue. Mostly when people talk about low oxalate diets, they are told to do that because they have a history of kidney stones. So sometimes when you have very high oxalates, you will get increased kidney stones. and that's how most people hear about low oxalate diet. But really, if you're trying to get your calcium up, trying to avoid these high oxalate foods is probably a good idea, and taking too many may affect absorption. Okay, so how do you get worked up for this? How do you get diagnosed with secondary? Well, first, I mean, you're gonna have labs, right? You're gonna have a calcium level, you're gonna have a PTH level. For anybody to even think about hyperparathyroidism, you check a PTH level. So we're assuming your PTH level is high. But what you want to do when working it up, and what I do, is review the diet and bowel habits. So I will ask everybody how many bowel movements they have per day. Are they loose? Do you ever get watery diarrhea? Because often that can reveal something that people often don't talk about. People don't usually start a conversation with, I've got watery bowel movements throughout the day. But that may be happening. They may have IBS, and that may be what's going on and causing this. Review the medical and surgical history. So it's really important, to know if you've had a bunch of your intestines removed, or if you have something like severe GERD and you're on a PPI. That gets to medications and supplements. So reviewing all those to see what else you're taking. Blood tests. I want to check the calcium and PTH. I want to check the vitamin D, since that can affect it. I want to see your kidney function. Again, unless you're in the really severe range, it's not that doing it, causing the secondary. And albumin levels. Albumin actually, it gives a sense of your overall health. It can be used in cases where if the albumin is very, very low, it can affect calcium levels. But really the albumin is kind of to overall check your protein status, basically. And for urine test, I want to check a 24-hour urine calcium if you haven't done it, because this is going to be to diagnose renal calcium leak. If you've got renal calcium leak, it's essential to check that 24-hour urine calcium and to know. If I see that your blood calcium level is low, but your urine calcium is very high, that's inappropriate. Your body should be holding on to the calcium. So if you've got high urine calcium, low blood calcium, that's renal calcium leak. And we're not going to know it until we have that 24-hour urine calcium. It's a hassle. You have to pee into a jug for 24 hours, but it's very helpful. Okay, so the diagnosis of each of these. So renal failure, again, you're near or you're on dialysis and you have very high PTH levels. They can go into the hundreds, the thousands. They get very, very high. Malabsorption, you're going to have possibly a surgical history of bowel disease. You're going to have a low urine calcium. So this tells me that the calcium's going through, you're not absorbing it. Whatever calcium you are getting, you're trying to hold on to, so you're not putting into the urine. We want to look at the medications and your diet also for malabsorption. For renal calcium leak, it's going to be a high urine calcium that's inappropriate for your blood calcium. Even a high normal urine calcium is inappropriate if your blood calcium is really low, right? The appropriate thing for a really low urine calcium, really low blood calcium, is to have a really low urine calcium. But if it's high, that's renal calcium leak. And finally, to diagnose the inadequate calcium issue, you kind of have to rule out the other things first, and then look at any dietary restrictions, history of parathyroid surgery recently, and look at the diet. Okay, so what does secondary hyperparathyroidism look like? Well, this is not the best representation of parathyroid glands, but it's the best I could find. So these are what normal parathyroid glands should look like, right? They're tiny, they're orange color, they're soft, they're floppy. Most people with secondary hyperparathyroidism will have glands that are pretty normal. They are overactive. They're making too much hormone, but they still look pretty normal. It's not like primary hyperparathyroidism where they have an obvious tumor on them. One looks different than the other. These glands typically look normal, unless you let it go for a long period of time, in which case they will grow. It's like working out a muscle. The more you use your parathyroid glands, the more they have to churn out hormone. They are going to grow. They become hyperplastic. So you get parathyroid hyperplasia, which is enlargement of all four parathyroid glands. They usually aren't equally enlarged. So you'll even see here, sometimes there's one big one. There might be two big ones and a medium-sized one and one that's kind of normal in size. That's classic for hyperplasia. They don't grow equally. But this, again, is only happening if you let it go. And this is where we get tertiary hyperparathyroidism as well. So when the parathyroid glands get like this, it can look like they formed adenomas. They actually will look like adenomas sometimes, but they're abnormal and they are not able to turn off. So they're not able to function normally anymore. Normal glands, when you still have small normal glands, if you get the calcium up appropriately, they'll turn off. They'll be able to stop making too much hormone and they'll go back to normal. Once you have this, where they're all huge like this, they're not going to be able to do that. They can't turn off, essentially. So even when the calcium comes back up, they're still churning out hormone. That's tertiary hyperparathyroidism, when the calcium goes back to normal or even high, but the parathyroid glands simply cannot turn off anymore. That's tertiary. That occurs most commonly in people who have renal failure and end up getting a transplant. Because the transplant works, they can bring their calcium back up, but their parathyroid glands just won't turn off, and they end up needing surgery for that. But if you get to this point, then you're probably going to need surgery because your parathyroid glands aren't going to work properly. Okay, so the treatments. Treatments are a little different for each cause. If it's renal failure, the treatment is a kidney transplant. It's the underlying issue is the renal failure, so that is the ultimate treatment. But a lot of patients will also need parathyroid surgery if they're at the point where they're making a lot of PTH. And a lot of times that's PTH over 500. So if your PTH is consistently over 500 and you're in renal failure, there's a pretty good chance that even getting a transplant is not really going to bring that down, and you need surgery to do that. And medications. There are medications that are used to bring the PTH level and the calcium down for patients in renal failure. Okay. Malabsorption, really it's calcium and vitamin D supplementation. And if you can figure out the underlying cause, then treat that if you can. If you've had surgery on your intestines, you've had a gastric bypass, you can't really treat that underlying issue. The treatment is more calcium, more vitamin D. For renal calcium leak, you don't want to just start taking calcium and vitamin D because it's just going into your kidneys and going into the urine, and that's increasing your risk of kidney stones, right? So patients with renal calcium leak get kidney stones because they're releasing all that calcium into the urine. You want to stop that process, and that is treated typically with thiazide diuretics like hydrochlorothiazide. That medication will stop the kidneys from releasing so much calcium, keep the calcium in the blood, and that often fixes the PTH issue. If it doesn't, for example, if you've been losing a lot of calcium into your urine over a long period of time, then what you need to do is also supplement with calcium and vitamin D only after you start taking the thiazide diuretic to fix that, though. Okay. And finally, if it is just inadequate calcium, it requires calcium and vitamin D supplementation. You can't really get around that. A lot of times, what I'll see is doctors just giving vitamin D, and that may or may not, it's probably not going to work. If your diet truly is not getting enough calcium, or you have a problem with calcium absorption, just taking vitamin D may not solve the issue. Most people will need some calcium as well. Okay. So that's all, and the timing was perfect, which is great. Okay, so I hope everybody understands it now, understands some of the differences, and how we can distinguish primary from secondary, and why they can't coexist. They are separate conditions. They manifest differently. They have different causes and they have different treatments. There can be overlap, though. There can be gray zones, and I'll talk about that next time. We're going to go over normocalcemic hyperparathyroidism next time, because that's where the gray area is. In both primary and secondary, you have a high PTH level. In primary, remember, you have high calcium. In secondary, you have low calcium, but not always. And there is significant overlap. When your calcium's normal, it requires a little bit more investigation to figure out is this primary or is it secondary? In most cases, you can figure it out, but it's not coexisting. I will see doctors sometimes diagnose primary and secondary. No, you have one or the other. If you have long-standing secondary that has led to a normal or high calcium level, then that would be tertiary, especially if it's high. If the calcium level is high now, but you've had long-standing secondary due to something else over many years, that is called tertiary. It looks a lot like primary, but it's not. It's a long-standing secondary. Okay, so perfect timing. I am going to answer some questions. Okay, so hopefully I've answered some of these during the talk. Liz says she's feeling much better since surgery. I'm so glad to hear that. And the question is, what tests can confirm secondary? It's what we talked about. So really, calcium and PTH levels are what you need to diagnose parathyroid disease, either primary or secondary. And sometimes you need to get a series of them, but in a lot of cases, just a couple of labs will show you pretty clear primary or secondary. Okay, Rachel asks, will hypercalciuria after successful parathyroid surgery 6 months ago lead to secondary hyperparathyroidism? Yes. So I actually have patients, not a lot, but I have a series of patients that have had this. So basically, they have classic primary, they get surgery, it's successful, they've got a classic parathyroid tumor, or tumors, and take them out, and the lab's correct. But then afterwards, they develop secondary, and they're taking calcium. When I check their urine calcium, it's really high. That is renal calcium leak. And I suspect some of that was probably going on even before the surgery because that was happening, but you couldn't diagnose it because the blood calcium level was also high. And so you expect the urine calcium to be high. But then after surgery, the urine calcium is still high, even though the blood calcium is now in the low to low normal range. So that does happen. So if the hypercalciuria is not correct, then it's renal calcium leak. As far as the underlying cause of the hypercalciuria, this is often not known as well. Your kidneys otherwise look normal. The function of your kidneys is normal. They're otherwise filtering things out. It's just that the urine calcium is high. Now there are other things, and this gets into what if you can't take a thiazide diuretic. That can happen because thiazide diuretics are used to treat blood pressure. Some people can't tolerate it. They're used to treat high blood pressure. So if you're walking around, your blood pressure is already normal or on the low end of normal, and you take a diuretic, you can drop your blood pressure further. The thing about that is usually we give really low doses. People can take very, very low doses of this to treat the renal calcium leak, much lower than than they would take for the blood pressure. So you can give somebody hydrochlorothiazide even if they have, a normal blood pressure. But getting back to this, so other causes of hypercalciuria, so there are other things like sodium. High sodium in the urine will pull calcium. So if this is an issue, really you want to do a full analysis, a 24-hour analysis if you really can't figure it out. But look at the sodium levels in there. Sodium pulls calcium. If that's the case, you can try to lower your sodium content. It is a really difficult problem if you can't figure it out and you can't take a thiazide diuretic. In that case, you're kind of down to hydration and other ways of preventing kidney stones, because one of the issues is really just preventing kidney stones at that point if your urine calcium is high. So yeah, tough problem, but if you have, it's getting a little advanced now, but it is an issue. Okay. Justin says hi. Katie says hi Justin. Katie says my calcium started increasing in 2024. Then at this year's annual physical, it was 10.3. So we started testing calcium and PTH. Calcium was 10.3, PTH was 41, vitamin D was 45. Around this time, I stopped all supplements. Okay, that's good. Yeah, you want to stop the biotin. Over the last couple of months, my vitamin D has dropped back to low and my calcium also dropped. 10.2, PTH was 13, and then calcium was 9.3, PTH 47. I was thrown off by the lower calcium and PTH values. I'm wondering if this is low vitamin D masking the hyperparathyroidism. Okay, so that's a weird question. So Katie, it matters how old you are. If you are in your 20s, then your calcium levels are normal, and that's fine. Then full stop, we don't really need to do much more investigation because PTH levels look good. And yeah. Now, if you're older than that, if you are in your 40s or higher, then these calcium levels are high. If you're in your 30s, they're kind of borderline. I'd want to see some more. But if you're in your 40s, these calcium levels are high. The labs from August are consistent with primary hyperparathyroidism, but not exactly diagnostic. I would want to see more based on that, especially since the PTH is kind of at the 40 range. Typically with primary hyperparathyroidism, we do see it kind of go up a little bit. 40s to 50s is, that's still normal, but that can be primary hyperparathyroidism. The PTH level is in the teens or the 20s, then it's less likely. But your next labs are kind of weird. So the 10.2 and then the PTH of 13, I don't know about that one. PTH of 13 is suppressed. You can get that if you were taking the biotin at the time, but you said you stopped. So I'm not sure what's going on. And then finally, the one after that, the calcium is 9.3. That's actually a little bit on the low end. And PTH is 47, which is appropriate. And vitamin D is 29. So your vitamin D levels, yeah, they're fluctuating a little bit. They're not going extremely low. The low vitamin D is not masking hyperparathyroidism. That's not really how it works. So with primary and secondary, you can see low vitamin D levels. And actually, with primary, it's very common to see low vitamin D levels. So it's actually more consistent with primary hyperparathyroidism if the vitamin D level is low. It's not going to mask hyperparathyroidism. Would this be secondary or still be primary? It's not. Remember, if you have high calcium levels, then you don't have secondary, right? Then you don't have secondary. With secondary, you have to have normal or low calcium levels. You can't have high calcium levels. So if you're over the age of 40 and your calcium's 10.3, it's definitely not secondary. But this doesn't look like, even if you're in your 20s, this doesn't look like either. Would this be secondary? It could be neither. Honestly, if you're young, then it's neither. If you're older, then it's a confusing picture. I think that we would want to see it more, actually, because the PTH level is going all over the place. I don't know whether to trust the 13, and the calcium's going all over the place. I would I would want a few more sets of labs, and I especially want to know your age. Okay. Justin asks, would I be considered secondary with FHH and symptoms? Oh, so this is tricky. So FHH is a separate topic. And FHH is difficult because with FHH, you have high blood calcium lifelong. It doesn't get better with surgery. That is your baseline calcium level. And you typically have very low urine calcium. It's part of the diagnosis, hypocalciuric and hypercalcemia. So low urine calcium, high blood calcium. Can you develop secondary with that? You certainly could, because if your calcium level is lower than what your baseline is, then your parathyroid glands could be overactive. But what happens with FHH is that you get hyperplasia of the glands, mild hyperplasia of the glands over time. So you can get a rise in PTH over time, even without secondary, just as part of FHH. FHH is a weird one. A lot of times it doesn't need surgery, but you can end up needing surgery if the calcium or PTH get high enough and they stay high. More advanced topic, I guess. Okay, Anna asks, my PTH is as inappropriately normal with calcium which is what clued us in on me possibly having hyperparathyroidism, which was then confirmed after surgery. Now I have a PTH of 43 and a calcium of 9.3 and feel perplexed about what is normal for me. I've been told it's about the calcium level, but then questions arise about normal calcemic hyperparathyroidism. Okay. Can you speak on what would be normal relationship for someone's PTH and calcium? And if calcium is the problem, how does one account for normal calcemic? Yeah, so that's the thing. Normal calcemic is tricky. That's why we're going to do a whole thing on it next time. But these labs actually look great. So most people are in the mid to high nines. Some people have calcium levels on the lower ends of the nines, and that's normal for them. A 9.3 is kind of mid-range calcium. That actually looks great. A PTH of 43 is completely normal. It's on the lower end of normal. So these labs look great. So it looks like it's probably normal for you. The other issue is, if your calcium level is consistently 9.1 and your PTH level is consistently 30, is that a problem? I tell people, it's often mid to high nines. That's not mid nines, that's low nines. Some people live in the low nines. If your parathyroid glands are not reacting to that, if they are making a low normal amount of PTH, then they're okay with it. And this assumes you haven't had surgery, you're not on massive amounts of calcium, all of that. But if you're just walking around, your calcium's 9.1, your PTH is 25, 30, that's probably your level. And that's what I would say about this. If your calcium's 9.3 and your PTH is 43, that looks great. So it looks like there's no problem now. And normal calcemic, we will get to. What would be a normal relationship? So there's also confusion about the relationship within a normal range. So a lot of people will ask me, well, my calcium, or they'll say to me, my calcium was 9.4 with a PTH of 40, and then the next week it was 9.6 with a PTH of 45. Shouldn't it, be inverse? If the calcium goes up, the PTH should go down. Not exactly. That is true if we're talking about outside the normal range, but it's not true if we're talking about within the normal range. So having the, the calcium go up a tiny bit, still within normal range, having the PTH go up a tiny bit, still within normal range, that's fine. They can move together as long as they're both staying in normal range. So that inverse relationship does not hold up if we're talking about truly normal labs. Okay. All right, so what Justin says, is it possible to have FHH and primary? Tricky, but yes. So FHH is its own beast, but as I said, you can develop hyperplasia with it. You can get parathyroid adenomas with FHH. And the key with FHH, so FHH, again, this rare condition, it's a rare genetic condition that causes you to have lifelong high calcium, typically low urine calcium levels. And the PTH levels are often in the high normal range. But if at some point the calcium level spikes, so if your calcium level is normally in the 10s and now it's 12, or your PTH level is normally in the 70s and now it's 150, then that requires surgery. So some people with FHH do require surgery if there's a major change in their labs. If it looks like the calcium is now above the baseline and the PTH is way above the baseline, that would require surgery. So is it primary? Sort of. It's like developing primary hyperparathyroidism on top of FHH. Okay. Celeste says, high PTH fluctuates and so does vitamin D, but calcium stays normal on the higher end, 9.3 and above. So 9.3 is not higher end. Remember, for milligrams per deciliter, it's mid to high nines. So 9.3 is kind of on the lower end of that normal range. And if your calcium level's typically staying in that range of the low nines, then a high PTH would indicate likely secondary hyperparathyroidism. Now, I would want to see the results. So I usually don't definitively diagnose secondary unless I've seen a few labs. I like to see a series of them. If your calcium level was 10.5 last week and it's 9.3 today, Again, that's not secondary, right? You don't get high calcium levels with secondary if we think it's real, not a mistake, whatever. But if your calcium level does that, kind of goes in the 10s and the 9s, that's not secondary, that would be primary. If your calcium level consistently stays in the low 9s, maybe high 8s, that looks like secondary. Okay, Me asks, 53-year-old, okay, thank you for saying the age, that makes a difference. Calcium is 10.8, PTH is 136, and vitamin D is 20. Okay, just from that, this is primary hyperparathyroidism, right? Your calcium level is high for your age. PTH is high for anybody's age. Vitamin D is low. This is classic primary hyperparathyroidism. And so were your labs after that. Okay, back to 2023. All right, so then you had surgery in October. Before the surgery, the PTH was 205. The calcium was 10.4. They took out a pretty big parathyroid. They took out 3 parathyroids, and the 4th was biopsied. Part of it was transplanted in the chest, and you were diagnosed with nodular hyperplasia. This is not secondary. This is primary. So with primary, remember, you can get an adenoma, like a single adenoma, and you can get hyperplasia. Hyperplasia does not equal secondary. Every patient with secondary hyperparathyroidism who needs surgery will have hyperplasia. But not every patient with hyperplasia has secondary. You had pretty classic primary hyperparathyroidism, and it was caused by hyperplasia. All 4 glands were involved. That's okay. That happens. That happens in about probably 10% of people with primary hyperparathyroidism will have hyperplasia. So your case looks like primary. Now, the one exception would be if you told me you were on dialysis for years and you had a kidney transplant and then you had the numbers looking like that, because then that might look like tertiary, but that's a very specific scenario. Okay. Linda says, chronic low magnesium and secondary hyperparathyroidism due to low vitamin D3. So yeah, that's a cause. So magnesium is interesting because it is really important for calcium absorption and metabolism as well. So I didn't cover that, but if you're not getting enough magnesium, if your magnesium levels are too low or too high, you can have a problem keeping your calcium up. And you're taught in med school that if somebody has a really, really low magnesium level, it's nearly impossible to get the calcium level up to normal. You have to replenish the magnesium as well. So magnesium is pretty important. Okay, Rachel asks, can chronically low lipase cause problems with absorption of vitamin D and calcium? I suspect I had acute pancreatitis many years ago, which may have led to my chronically low lipase. I don't have chronic diarrhea now. At fasting, my post-op labs are 8.8 of calcium, 58 PTH, and 8.9. Not fasting, 9.5 and 9.7. So it's interesting. So having these issues, especially, other malabsorption issues can definitely affect it, especially if there's a problem with fat absorption. You can have a problem with absorbing vitamin D, and that leads to problem absorbing calcium. So it is possible that that may be affecting it if you're having problems absorbing the vitamin D. And your vitamin D is a little bit on the low end. It would make sense to check it. Now, it's a little bit weird that there's such a difference between fasting and non-fasting. Typically, we don't see that unless by not fasting meant that you popped a bunch of calcium pills prior to doing labs. It's a little strange that there was such a difference. Okay. Oh, Celeste asked, do calcium channel blockers skew tests? No, even though it's in the name, it's not really going to cause a big deal. So you can continue your calcium channel blockers. It's not affecting anything. Michelle asked, how low does vitamin D have to be for secondary? It's a good question. And the answer is, it varies. So in studies, when we look at vitamin D, you'll see the normal range for most labs as 30 to 100, which is way too high in nanograms per mil. But the evidence we have for actual problems with calcium absorption with vitamin D come from levels that are below 20 and often below 12. So that's when you get conditions like rickets or osteomalacia, when you have these really bad problems with calcium in the bones. So how low does it have to be? Well, probably 20 or lower, but if it's below 30, that could potentially bump up the PTH a little bit. You might not see severe low calcium levels with that, but you may see a bump in the PTH. So I usually, if I'm suspecting if somebody has a vitamin D level of 25 nanograms per mil, then I will try to get it at least above 30, more like 40 to 60 in that area, so that it's not the issue. Okay. Jacqueline, is there a PowerPoint slide for this chat? No, but all of this will be on YouTube. All of this will be posted on YouTube. Okay. Rachel, sorry, was talking about the urine calcium. So before surgery, urine calcium is 286. After surgery, 227. I mean, the 227 is still normal, but it would depend on what your calcium level was with that. It would, if your calcium level was very, very low and you were still putting out that high normal amount of calcium in the urine, then that would be inappropriate. Okay, so I'm sorry I can't sort of have a discussion on here because of the delay, but all right, so Justin says, this is about the FHH. You've got also a lot of GI issues. GI issues and calcium do go hand in hand. One second. All right. Sorry, had to transition there. My camera just died. Okay, so I'll get back to the question. So GI issues really affect calcium. I know it can be confusing, so it's kind of tough. You've got all these other issues. If your labs are changing, Justin, then you want to look into possible parathyroid disease or parathyroid surgery. Okay. Rotod, hello, says, good to see group members. Awesome. Okay. And Katie said, so Katie's age 34. You're in kind of a gray zone. When I was talking about your labs, I was like, well, if you're 20 and versus if you're 40, but you're actually in the 30s, could be normal. I think taking some vitamin D, rechecking labs in 6 to 8 weeks is totally reasonable. And that's a good plan. Okay. All right. I'm going to keep going with these. Okay. Sorry. So James says, I'm 53 years old, post-op 7 months, had 3 glands removed. Since surgery, I suffered with severe and progressive muscle weakness and now only have mobility to get around the house. Okay. I bounced around from endocrinology, neurology, etc. Everything points back to the surgery. Most recent labs, calcium 9.5, PTH 8, vitamin D 30, and mag 2.1. Currently getting 1,800 to 2,200 milligrams per day. Low PTH was normal before I had disease. Okay. Can hungry bone syndrome be causing this? Ooh, so it's interesting. I mean, your calcium levels look great. A calcium level of 9.5 is perfect. Vitamin D is a little bit on the lower end. You're taking a lot of calcium to maintain that calcium level. The PTH is interesting. So some people do just have lower PTH levels compared to the rest of the population. And maybe that is normal. Maybe you're just one of these people. But it looks like you're somebody who does need extra calcium. This is not hungry bone syndrome. Hungry bone syndrome is a very, very specific thing. Like it's a very severe condition. You're usually hospitalized with it. But I know what you're getting at, which is, not exactly hungry bone, but a necessary, need for calcium. Could this be causing the mobility issues? I don't know. That's tricky. It's not common to lose mobility and have severe muscle weakness, with the normal calcium levels. So unfortunately, I don't know. I don't have an answer for you. Unfortunately. Allison says, parathyroid surgery 2023, 2 adenomas removed, recent labs 9.9, PTH 22, and vitamin D 57. Recently discovered 67% right carotid artery stenosis. Could too much dietary calcium have caused this since surgery? Probably not. So your labs look perfect, right? The calcium looks great. PTH is low normal. Vitamin D is good. Now, dietary calcium. So dietary calcium tends not to cause issues. If you take a lot of calcium supplements, meaning you're getting more than 1,000 milligrams a day and you don't have any reason to take it, so you have no bone loss, you don't have any issues with absorption, then in the large studies, there is an increased risk of certain things like heart attacks and strokes. But that's, again, only for people who were taking large doses of calcium supplements without any indication. If you're just getting calcium from diet, then no. Dietary calcium seems to act differently. It doesn't cause that increase. We don't see any increase in those coronary events, any of those events, just with dietary calcium, because it shouldn't produce any spike in the calcium. That's the theory, is that it produces smaller spikes and more gradual. So could it have caused it? No. There are a lot of other causes for artery disease, and that's, and injury to the arteries. That's probably more likely. It wouldn't be the dietary calcium. Okay. And yeah, Justin, I know, yeah, you had the FCASR gene. So you do have FHH. We diagnose FHH with genetics, and you definitely have it. But you can also eventually need surgery or a second surgery, but your labs would change. They would have to look pretty different. Rachel asks, could overconsumption of calcium lead to hypercalciuria? That can be it. I mean, taking lots of calcium supplements will increase your urinary calcium. That is part of it. So yes, if you're taking a lot of supplements, that's going to increase the urine calcium. But again, the urine calcium should correspond somewhat with the blood calcium. So if the blood calcium is high, normal, and your urine calcium is also high, normal, okay, that makes sense. If the blood calcium is really low, but the urine calcium is high, that doesn't make sense. Okay, Anna says, my wording was really bad. Oh, I was inappropriately normal prior to surgery. So this can be confusing for patients, because when you're diagnosed with kind of normal calcemic, people sort of wonder, what is it going to look like afterwards? And the goal really is to keep the calcium in normal range, but then also have the PTH in normal range. But in order to be diagnosed with normal calcemic, you have to have all normal calcium levels. If you had calcium levels that were fluctuating into the 10s, then it wasn't normal calcemic hyperparathyroidism, it was primary, because primary does that. And if you're one of those people that has calcium levels fluctuating between normal and high, and then your post-op labs calcium's normal, well, that's great, but we want to make sure that it stays normal over time, and it should if you were treated. Okay. Laura Cooper says, I'm on thiazides for hypercalciuria 11 months after successful parathyroidectomy. Will I have to take thiazides for the rest of my life? I don't know. I really don't know. So for most people, I recommend staying on them as long as they're working, as long as it is keeping your urine calcium level in normal range. And I don't really recommend stopping it, because if you stop it, then you risk having that high urine calcium level again. Could something else change? Theoretically, yes, your health could change in other ways, but I do recommend staying on it for the time being if it's working. Okay. All right. People said thank you. You're very welcome. Ashley is a 33-year-old woman. Calcium was 11.5. That's definitely high for any age. PTH was 36. Okay. 36 is, low normal, but it's inappropriate still. End of August, the calcium was 10.9 and the PTH was 17. Had a consultation yesterday with a surgeon, and he made me more confused if it's primary or secondary and what's the difference. Yeah, so that's not secondary. Remember, with secondary, you have to have a low calcium level or low normal or normal potentially, but not high. These calcium levels are clearly high. The one thing I would note is that, especially with that PTH of 17 being in the suppressed range, I would want to see your vitamin D levels, because I do see vitamin D causing this kind of stuff. So if you've been taking high dose vitamin D and your vitamin D level is very high, then that could potentially be the cause of your high calcium. And surgery there is not really the answer. The answer is stopping the vitamin D. So make sure that you don't have a very high vitamin D level, especially with that PTH of 17. That's very weird, but it's definitely not secondary. You've ruled that out by having a high calcium level. And yeah, you've got kidney stones because you've got a high calcium in your blood and it's pouring into the urine. That's what the kidneys do. They filter it out. So you've got calcium pouring into the urine. Again, that's not diagnostic for primary hyperparathyroidism. It could still be vitamin D, but just check your vitamin D level. Okay. And oops. Okay, Rachel says, will you take a patient and do consultation to figure out? I do this all the time. I have a lot of patients with secondary who come to me. Some of them have been diagnosed with primary by their doctor. And then when I look at everything, it's clear that it's not primary, it is secondary. But yeah, I actually do a lot of consultations for people with secondary, and I help them try to figure out how to manage it. I am going to be starting a new course, basically, because secondary is undertreated and misunderstood by a lot of doctors. And you don't just need one consult. Sometimes you need kind of, a longer term, management of it. It's not just a once off, it's kind of longer term management and learning about kind of how to manage it. And it's not often an easy fix with secondary. So if the issue is malabsorption, it's not just taking a pill, it's figuring out why you're not absorbing it, trying to figure out what you will absorb. It involves trying different types of calcium usually. You may not tolerate one form, your intestines may not like one form, and then you have to keep trying. So it's kind of a longer term issue, but I do a lot of this. I do want to get started with an online support group and education group where we can sort of monthly talk about this and figure out how to manage it, because it's not always straightforward and doctors are not used to dealing with it. Okay, I think I got to everybody's questions. So thank you so much, everyone. This is almost on time. Sorry about my camera, get overheated, but next time I'll figure out how to keep it cooler. Some ice packs or something. All right, thank you everybody who joined. All right, take care. Bye.